Stanford University.
So what I'd like to do at the very beginning of this talk is introduce us, and I'll be introducing my team as they come along, just so you really can get to know us as well. And we'll then go into the regular talks of the session in terms of handling really a variety of, I think, a comprehensive discussion of various issues that will be of interest to you regarding atrial fibrillation. So this is our program. We're going to go through this rather quickly, but again, as Nora has assured us, you'll have all of this at your disposal. So I'll have some introductory comments about atrial fibrillation, as I've mentioned. Dr. Shah will speak in talking about the various pharmacologic therapies. Actually, Dr. Zai will then talk about anticoagulation. Dr. Al-Ahmad will talk about ablation and other surgical options. And then I'll finish up looking at the future of atrial fibrillation management, and then we'll go into our question and answer session. So really as a way for you to get to know us, if you don't already, this is our team, and I must say, as a director of this team, I'm really proud of the group of people that we have together. And what I'll do is I'll go through each of the people who are speaking today and a little bit more, so you'll, again, know a little bit more about this group. But as you see here, it's myself, Dr. Al-Ahmad, Karen Friday, Henry Shah, Mintu Taraki, and Paul Zai, and I'll introduce them individually. A critical component of our service, and those of you who know us in our service, you'll get to know the nurse coordinators that work with us. And these are spectacular individuals who really deliver outstanding care. And we're really, truly grateful for their being such a critical part of our service. This is the way I always start these talks, because this is how we try to run our service. And that's based on really what is our mission. And so our mission statement, as we created this several years ago now, it reads as follows. And it says, we're dedicated to delivering outstanding, compassionate care of arrhythmia patients while working with their physicians and advancing teaching and medical research in cardiac arrhythmias. And this is the pledge that we have to you and to your physicians that we take very, very seriously. Our vision for the program, indeed, as you'll hear a lot about, is really that the Stanford Cardiac Arrhythmia Program will be recognized as one of the top programs in the country, really focusing on this, the range of state-of-the-art care, being a leader in innovation, and I'll really emphasize that, as well as providing outstanding service and access. So this is a little bio of myself. I graduated from Harvard College, went to Columbia University for medical school, did my residency there as well, and then went to the Brigham and Women's Hospital in Boston, part of Harvard Medical School, and then I was on faculty for 14 years at Tufts University School of Medicine before coming here to be director of the arrhythmia program. You'll be hearing from Dr. Amin Al-Ahmad, who did his undergraduate work at Syracuse, his medical school residency, cardiovascular electrophysiology training at Tufts New England Medical Center. Henry Shah did his undergraduate work at Tufts Medical School as well, residency in University of Michigan, and then fellowship at Texas Southwestern, followed by electrophysiology at University of Pennsylvania, and was a faculty at University of Pennsylvania before coming to Stanford. Paul Zai did his undergraduate work at Johns Hopkins, then at Stanford, right here, did his MD, PhD, and then did his cardiovascular, his residency, and then his cardiovascular fellowship, electrophysiology fellowship at Brigham and Women's Hospital at Harvard Medical School, and served as faculty there. So as I think you'll, as you get to know our faculty members, I think you'll agree very much that these are really the top-notch people in the country. One of the things also that I really want to point out is that as you go across many of the top programs in the country, one thing you'll see is that A lot of them did their training and their work at the same institution. And as you see here, as we assembled this team, one of the things we clearly wanted to do was to get a diversity in terms of opinion, in terms of experience, and really be able to bring a dream team together. And I think we really have done that. And it really gives a special character to our service that I think really enhances our patient care. So I've listed 4 conditions, but obviously our highlight for this evening really is atrial fibrillation. And I'd like to just say some introductory comments about that. First, in terms of the initial evaluation, as you know, we would really start with really how people are feeling, how you might be feeling if you have atrial fibrillation, whether you have symptoms of dizziness, shortness of breath, chest discomfort, or even have loss of consciousness, we call syncope. We'll also be asking you about different factors, things that might precipitate atrial fibrillation. That could be exhaustion and fatigue, volume depletion, mental stress, exogenous substances like caffeine, alcohol, even disturbances of sleep and other forms of stress. As we look at this, we'll kind of basically try to define some very simple principles that you'll hear about. And so I wanted just to take a moment to do that. We'll talk about fast heart rhythms, and we'll talk about those as being a tachycardia, unlike what we'll say is normal rhythm, and we'll use the word normal sinus rhythm as being synonyms. Slow heart rates, which are slow heart rhythms, you'll hear being referred to as bradycardia or bradyarrhythmias. As you know, the heart has upper chambers, the atria, as well as the lower chambers, the ventricles, as shown here. And in fact, the heart rate reflects the pumping in the main pumping chambers, the ventricles, the lower pumping chambers. Conduction starts in the upper chamber and travels through a connector, which is called the AV node. It's like a staircase connecting the top floor of the building and the bottom floor of the building. So one of the very early principles, and we'll emphasize this through the talk, is really establishing the diagnosis. And that's really easily obtained through electrocardiographic diagnoses, a routine EKG, a monitor, an ambulatory monitor of some kind. As I mentioned, the heart chambers that we're focusing on are the upper chambers, the atria. And as illustrated in this diagram, and the little arrows that are going every which way really indicate the electrical activity is very disorganized in atrial fibrillation. And I use the analogy that it's like a sandstorm or a windstorm. It's blowing all around very, very rapidly, many hundreds of beats per minute. As a way of introduction, what is the magnitude of atrial fibrillation? Very large. Over 2 million in the United States alone, patients have atrial fibrillation, and this is dramatically rising. That's very much reflected by this figure. And so in the dotted line, you see, in fact, the U.S. population, and you see the baby booming population there as a peak, as you see. And in the bars, that represents the incidence of atrial fibrillation as a function of years. And as you easily can see in this graph, atrial fibrillation is centered around the ages of 60 and 80. And so you can imagine as our population is aging, that number is going to exponentially grow. And that's indeed the phase in which atrial fibrillation is growing in our population today. Classification. You'll hear some words that will be talked about, so I thought it was useful just to say a word about this. We typically make a distinction between what is called paroxysmal atrial fibrillation, that is atrial fibrillation that terminates on its own, will come and go, as opposed to other episodes of atrial fibrillation that we might say are more persistent, that is, may require an intervention such as a medication or a shock to convert their rhythm, etc. Other people may use at times chronic or that kind of thing, but these are sometimes the most useful forms of terminology. The other word that people will talk about, and so I wanted just to take a moment to introduce that, is that of catheter ablation. And so this refers to small plastic tubes called catheters that are inserted through the arteries or veins into the heart. And so the site of origin of the rhythm problem is then zapped, which means that we kill islands of cells responsible for that heart rhythm problem. The first form of catheter ablation was for supraventricular tachycardias, a little different, still in the upper chambers, but a little different than atrial fibrillation, and that was developed about 20 years ago. And indeed, it's become really a mainstay of treatment, but is a little different than that what we'll be talking about and you'll hear extensively about during the talks today. There are certain forms of catheter ablation, both heating and highlighted here in terms of that of freezing the tissue. So next I'd like to turn the program over to our first speaker, and that is Dr. Henry Shaw, who I've already introduced to you. And he's going to give us a perspective in terms of what we call rate and rhythm control and the role of drug therapy. So it's my pleasure to introduce him to you.
I'm going to talk about drug therapy, especially the concept of controlling the rhythm versus controlling the heart rate, and as well as a therapy called the AV nodal junction ablation. And I'm going to leave the atrial fibrillation ablation, the actual ablation of atrial fibrillation, to Dr. Al-Ahmad. As Dr. Wang pointed out, that atrial fibrillation is the most common rhythm problems in the world, and these are the data from California HMO, and it's right now in the 2010 we projected 2.6 million people, but by 2050 the number will double at least. So it is a growing epidemic. And we've seen this before as the population, this is the US population, but this is a disease that the incidence increased dramatically after the age around 60. And it is a disease with many different risk factors, which include hypertension, structural heart disease, and alcohol, and caffeine, et cetera, or sleep apnea. So as the population age, there are many other risk factors that plays into this rising incidence of atrial fibrillation. So first, I'm going to talk a little bit about the drug therapy. These are the older data. The purpose of, I don't want to bore you with all these different figures, but this is an analysis of some of the older drugs that's used to control the atrial fibrillation rhythm. And on the top panel, you see that these are the medications, and here is the percentage of the patient that's remaining sinus rhythm at 6 months. Again, these are the older generation of drugs that's used to control atrial fibrillation, and the overall efficacy of these drugs are not great, about 50%. So, in 6 months, if you take these medications, there's about a 50-50 chance that your rhythm will be controlled. And, but again, sometimes it depends on how you look at it. Either the cup is half empty or half full. So, but the important thing is the older generation drugs are not so great. So, so in terms of what kind of drugs, well, there are drugs that we use to control the rate. Again, like Dr. Wang mentioned, atrial fibrillation can be associated with a very fast heart rate, and that creates a lot of symptoms. Or there are drugs that, so therefore we can give drugs to slow the rate down a little bit for symptomatic control. The second type of drugs are the drugs that actually are used to control, to maintain a normal rhythm, to prevent the recurrence of atrial fibrillation. And those are the medications that actually act on the heart cells themselves. And the previous slide I showed you earlier were the medication that's actually used to maintain the normal rhythm. But the overall success rate in these drugs are at least not the older generation drugs are only about 50%. And we select these drugs mostly based on the safety profiles and the compliance of the patient. So a drug that's given 3 times or 4 times a day are generally poorly tolerated than a drug that's given once a day. And also these drugs tend to have various different side effects. So the long-term efficacy of drug therapy for controlling of atrial fibrillation is somewhat limited. So the age-long argument is what are the different strategies we have to treat this very, very common problem. One strategy is what we call control the atrial fibrillation to restore normal rhythm. Then if you have normal rhythm, then none of the symptoms you have associated with atrial fibrillation, will become a problem. And the second approach is, just to control the rate and leave the patient in the atrial fibrillation. And there are advantages and disadvantages, the pros and cons of each approach. Now, to control the rhythm, like I mentioned to you earlier, the efficacy of these drugs are only modest at best. If you control the rhythm, obviously you control the symptoms and patient feels better. It may minimize the need for long-term blood thinner or anticoagulation, because as you will hear from Dr. Zai, that one of the main cause of morbidity and mortality is strokes associated with atrial fibrillation. So obviously, if you can maintain a normal rhythm, you may be able to minimize the need of atrial fibrillation, anticoagulation, and also to prevent the various different remodeling process and prevent the progression of the intermittent atrial fibrillation all the way to the permanent or chronic form. But there's a price to pay. That these drugs, although it's modestly effective, they are not, the recurrence rate is high in the long term. And in order to maintain a normal rhythm, you have to take drugs probably for the rest of your life. There are many different types of side effects, and sometimes they actually can cause potentially life-threatening side effects of inducing a more dangerous rhythm than atrial fibrillation. So these are the trade-off. Now, the other approach is just to control the rate. Now, that's a little bit easier because you can just give beta blocker or calcium channel blocker, and those are common drugs that's used for hypertension and many other disease states. And these are usually well tolerated, and so it's easier to control the rate than to actually control the rhythm itself. And these drugs generally have very little risk of causing a further rhythm problem, or more dangerous rhythm problem. But controlling the rate doesn't necessarily eliminate the symptoms, and doesn't prevent the progression from intermittent form to a more permanent form of atrial fibrillation, because you're really just leaving the patient in the rhythm, in the arrhythmia itself. And if you give a little too much, the patient's heart rate may get too slow, and you end up with a pacemaker, and it does not obviate or eliminate the risk of strokes. So your patient still have to take long-term anticoagulation. So one of the large trials that was recently, well, not that recent, a couple of years ago, that was published that comparing which approach is better. I mean, this is a very large trial involving over 4,000 patients, and with a persistent form, and they want to compare the efficacy or the long-term effect of maintaining the rhythm versus just control the rate. And it turns out that in terms of survival, both groups do just fine. There's equal survival. So that led to a lot of people to believe that, there's no really benefit to control the atrial fibrillation to maintain rhythm, because the survival rate is the same. We're not even talking about quality of life. But is that what we really learned from this trial? One thing we do have to remember, that this trial, you generally include patients in the elderly group in the 7th decade of their life, probably. Many of them has a lot of other risk factors, high blood pressure, and also coronary artery disease. Many of them have enlarged atrium because so these are not these are more advanced form of atrial fibrillation in an elderly patient with a lot of risk factors, and these patients has no symptoms. So this results, although it's a very important study, may not apply to everybody with atrial fibrillation, even though the drug options for rhythm control is not great, but does this, is there other therapy that's available that can help us to control atrial fibrillation, such as the ablation of atrial fibrillation, or is a newer drug, would that be better than than the data from 2002? So this is actually, I hate to show these graphs, but so if you actually look at these patients from this study, And basically, they went back and did this whole analysis. They say, yes, the survival rate in these patients, whether or not they receive drug to control the atrial fibrillation, or they just receive medication to control the rate itself. They have the same survival rate. But if you look at what they went back, did the statistical analysis, and they found that this is what they call the hazard ratio, meaning that the risk of dying. If normal is 1, and being in the normal rhythm is half of the risk. So a normal rhythm indeed is better for the patient. And another important thing is that these patients, as long as you take the warfarin, the anticoagulation, your risk of dying is halved, because it's 0.5 compared to a normal of 1. However, when you use drugs, or at least the older generation drugs, your risk is 1.5 times of dying. So it is interpreted that the reason that patients use drugs have the equal survival rate is because the benefit of achieved with drug in maintaining the normal rhythm is offset by the side effect of the drugs. Because the 1.5 is a 50% risk using drugs, but you have a 50% survival benefit. So if you use drug to control rhythm, you got a number of 1. And that has been brought out with other studies. So what are there are some newer drugs, such as this drug called the Defitelide, which showed that it is effective in maintaining a sinus rhythm. And obviously, one of the most common drug is called amiodarone. And the amiodarone is superior than sotalol or placebo. So that is probably the most effective drug that we have, that we have had in the last 10 years. Now, more recently, I didn't put the slides in here. There are newer drug called the dronedarone, who just came out, which is the analog of amiodarone. That turns out to be, although not quite as effective as amiodarone, but it has it has really much less long-term side effect that we know of compared to amiodarone. So that may become a very popular and very viable option for controlling atrial fibrillation. And this, I just want to show you that this is the official recommendation from the American College of Cardiology and American Heart Association and European Society of Cardiology, and their guideline of managing patient with atrial fibrillation. So if the goal is to maintain sinus rhythm, so it seems if you really delve into the data, that the sinus rhythm is good. You should always, you probably should have what God gave you when you were born, but we have to find a way to achieve that without the side effect of a lot of these antiarrhythmic drugs. And it's divided into different categories. The patients are divided into different categories, and there are various different drugs that's recommended. So the drug therapy at this time is still recommended as a first-line approach. But catheter ablation has moved from the previous, this is in 2006, 2002, the catheter ablation was even one level lower. So, but given the efficacy of catheter ablation, and it's being moved up as a second-line therapy. And it may even become a first-line therapy, but I'm going to leave that to Dr. Al-Ahmad. So in summary, in terms of the treatment of atrial fibrillation, again, there are different types of atrial fibrillation, and there's patient age, there's younger population versus the older population, and the catheter ablation may be assuming a greater role in this type of scheme that in the earlier form of atrial fibrillation or in the younger population, it's probably the mainstay therapy, whereas the antiarrhythmic drug is, although effective, but it's used as more adjunctive therapy to catheter ablation. And I think, well, I just want to talk a little bit more because that was the topic that was given to me, is that one thing that is to, in patients who have who is in atrial fibrillation, who cannot be, whose heart rate is difficult to control and does not respond to drugs, one of the options is to ablate this, what we call the AV node, like Dr. Wang showed you earlier. We put a catheter there, we burn out the connection between the upper and lower chamber, and obviously the patient will most likely receive a permanent pacemaker as backup. And when that happens, we turn on the patient had very rapid symptomatic atrial fibrillation. We turn on the energy, and the heart rate suddenly slowed down because now the conduction from the upper chamber going at several hundred beats a minute has been eliminated. And then patient has a fairly slow and regular heart rate. Now, this type of approach is highly effective, but it's used mainly for symptomatic control in patients who have permanent form of atrial fibrillation. And many studies have demonstrated that before the ablation for rate control and after the ablation, the exercise tolerance improves significantly, that the heart function increase or improve after you control the rate, because sometimes the rate itself during atrial fibrillation could be detrimental to patients' overall heart function, and the heart shrinking size, and patient actually have significant benefit from this type of approach as well. But this is only reserved for patient who has permanent form of atrial fibrillation, and it's used to control the symptoms. I think I will stop right here, and we'll leave the question for later. Thank you very much.
First of all, thanks a lot for your patience and your attention tonight. Those of you who have AFib, this might be sort of a nuisance topic or a boring topic, but in how we look at patients with AFib, it's actually a critical topic because managing stroke risk is really probably the most devastating outcome of having AFib that we want to try to prevent. And so that's the topic I'm here to talk to you tonight about. So for my little section of the talk, I want to talk about a few points here. One is, why is there a stroke risk when you have AFib? Just explain the sort of pathophysiology. And what is the stroke risk? Meaning, if you have AFib, what's the likelihood that you might have a stroke? And who are the patients or folks that are most at risk for having a stroke? And then, of course, what are your options for managing that risk of stroke? So as Dr. Wang's already explained, but I just wanted to make sure to sort of hammer home the point. So AFib is an irregular heartbeat. It's caused by chaotic electrical firing and twitching of the upper heart chambers, the atrium. In EKG, you can see very clearly the difference, even for lay folks, where in normal rhythm up here, there's a very regular electrical activity in the heart, while in AFib there's this underlying chaotic activity and a lot of sort of irregular heartbeat activity, as you can see there. And what's going on there physically? So this is the left side here is another version of the cutaway picture of the heart that we've all been showing. And you can see in these upper chambers, when you do have AFib, the electrical activation is just very chaotic and non-uniform, and it sort of triggers the lower chambers to then fire along and keep up with things. And when that happens, blood flow is very poor. The blood undergoes what we call stasis, meaning that when blood pools, then that's sort of a trigger for the clotting cascade or the clotting process to form. And in fact, if you look very closely at one particular portion of the anatomy of the upper chambers, the atria, get this pointer to show this little flap here in the left upper chamber, which is called the left atrial appendage. If you look at that up close, this is an anatomic specimen. It's a very complex sort of multi-layered branching structure. And this is an ultrasound picture of it during a patient study. You can see it's this long branching structure. And you can imagine if blood flow is very poor, and on top of that you have this very sort of circuitous and complex structure here. This is a very good or you can say bad candidate for where blood clots can form. And in fact, studies show that well over 90, probably 95+% of all blood clots form in this specific area of the left atrium. Why am I mentioning this? Well, it's important in terms of thinking of potential therapies for managing stroke. So to get back to what I mentioned earlier in terms of who is at risk. So we've developed, we meaning medical specialists have developed actually a pretty simple chart for determining who is at risk for stroke. So when you have AFib and you have this stasis, actually it turns out not everyone develops a stroke. Some folks can just go on without even doing anything and probably not have a stroke, while some folks, when they have AFib, the risk of stroke is extraordinarily high. And using sort of epidemiology studies and large clinical studies, we figured out at least 5 major risk factors for stroke, and I've listed those here, and we've called these the CHADS score, CHADS, and that just stands for these 5 factors. C for something called congestive heart failure, which is when your heart function is inadequate enough that you develop symptoms related to that, breathing trouble, shortness of breath, chest discomfort perhaps, fatigue, that kind of thing. Hypertension or high blood pressure is a risk factor as well. An older age, so it's a relatively strict cutoff, but as you get older and older, your risk for stroke certainly increases, and diabetes as well. And then, as you can imagine, if you've had a stroke or what we call mini stroke or TIA in the past, then you certainly are at risk as well. And we generally use a very vague or rough calculation that if you have, so each of these factors gets essentially 1 point, except for the last one, the history of a stroke, which gets 2 points. So if your score is at least 2, then we really strongly want you to consider at least a more aggressive approach to managing your risk of stroke. So how do we do that then? So you can imagine maybe a few different options for doing that. You can take medicines to thin your blood so that your blood's less likely to form those clots when you're in AFib. So that turns out to be the mainstay of how we treat stroke, or the stroke risk, and I'll talk about that in probably the most detail. So you might also imagine if we can reduce the burden of AFib, meaning the fewer episodes of AFib that you have, less likely a risk of stroke. Well, it turns out there's really very, very little clinical data to support this theory, this hypothesis. It may actually be true. We don't know, but we don't really, unfortunately, have any solid data to really tell us that is indeed the case. So that's an very important point, because at least when I talk to my patients about various strategies to manage stroke risk and manage AFib in general, the issue of reducing or controlling the burden of AFib, meaning that your symptoms related to your AFib, I really try to at least mentally separate that out from discussions about what your stroke risk is and how to manage that. So it's almost like 2 separate discussions or 2 separate things to consider when you talk about AFib. And then there are newer strategies as well, so I just want to talk briefly about that as well. There's exciting technological developments that are coming to light as we speak, and these involve primarily basically getting rid of or cutting off that left atrial appendage, that little segment from the rest of the heart where the blood clots do seem to form. So in terms of blood thinners, there are several established options, and some of you may have heard of some of these options. So of course everyone's heard of aspirin for pain relief. It turns out aspirin is a very mild blood thinner, and because it's so old and well established, it's been studied extensively in terms of its effect on managing stroke risk. Plavix is a similar type of blood thinner in that it affects a component of the clotting process called platelets as well, but it's stronger than aspirin, and it acts in a slightly different mechanism. You may also all be aware of something called warfarin or Coumadin. It's probably the bane of the existence of most patients with AFib, but it's an important thing to discuss. So, and then of course we are always looking for newer agents to control AFib, and if you keep up with the popular press, there actually are some that are very promising as we speak. So again, just like Dr. Shah mentioned, I don't want to bore you with too many data slides, but this is just to give you a general sort of sense of things. I have just 2 of these. One is this is a graph that just compiles a few of the important studies that look at how effective is aspirin in reducing stroke risk. And if you just look at that this graph, and just the simple way to look at this is this middle line is the sort of even point. If the study data shows that the results turn out in this right side, then aspirin does worse than just leaving the patient alone, while if the study shows that all the data ends up on this left side, then aspirin is better than leaving the patient alone, meaning placebo. And you can see in at least all the major studies that have been published, aspirin is clearly more effective than just placebo in reducing the risk of stroke. So that's pretty clear, and that's very well established. So how about warfarin? So warfarin's even better, actually. So not only, so it's the same kind of a graph, and there's been much more data presented about warfarin in this particular arena, but warfarin has not only a more effective, higher degree of effectiveness compared to not using warfarin, but many of these studies actually directly compared to aspirin. So what we can say actually is that warfarin is clearly superior to aspirin. But just like everything in medicine, there is everything we decide to treat with, usually the higher the effectiveness, the higher the potential risk of side effects and complications, and that goes for this as well. So warfarin is a more aggressive blood thinner, so likely your risk of having bleeding complications is a little bit higher. So again, just like if you think about anything we do in medicine, we have to weigh the risk of complication with the efficacy or benefit of the therapy that we're recommending. And that goes with all of these treatments. So then when we decide on which treatment, then we sort of overlay this with that sort of risk factor list that I mentioned, the CHAD score. And if your risk is high enough, then that's when we push you more, or at least to have the discussion more towards, you should at least consider warfarin. And if your risk is lower, then we say that aspirin is likely to be adequate. And that's the discussion that we generally have with patients with atrial fibrillation. Now, there are newer agents that are available. I don't want to spend too much time just going over the studies, but suffice it to say that the problem with warfarin in particular is that it is a medicine that's notorious for having several problems. One is interactions with many different medicines and your diet. And so taking it is very difficult for many patients in that you have to watch your diet, you have to watch what other medications you start. And on top of that, just the efficacy from patient to patient can vary. And so you have to check blood levels of your blood thinness on a periodic basis. So you have to go into a blood lab every few weeks, kind of a thing. So that becomes very cumbersome for many patients. So these newer agents, the goal of all of these is to try to achieve a similar efficacy to warfarin while trying to eliminate some of these problems. And the newest agent, which there was a study just published recently in the last week or so, or a couple of weeks or so, that shows that there is significant promise. And if you, I think, wait just a short period of time, this may very well be something that would be quite effective, and may, in fact, hopefully, we're always looking for the medication that's going to eventually replace warfarin. What about the other things I mentioned? Oh, about Plavix. So unfortunately, Plavix has some increased bleeding risk over aspirin because it's a little bit more effective, but the data for Plavix over aspirin isn't convincing enough for most physicians to say that you should take Plavix over aspirin alone, at least. So how about reducing the burden of AFib? So I already mentioned that unfortunately, I'm not convinced that there's enough evidence that just by reducing how much AFib you have, you can say that your stroke risk is back to the risk level of someone without AFib, for instance. Now, certainly, the problem is that, every treatment we use, whether it's a surgical treatment or a catheter ablation treatment or medications, none of them we can guarantee 100% efficacy. So if say you undergo catheter ablation, I wouldn't want to bet that X% of recurrence that you stop Coumadin, for example, and then expose yourself to the risk of stroke. So again, to hammer home this important point is the discussion about whether or not to be on anticoagulation or of some kind is considered separate, at least in my opinion, from how you treat the burden of atrial fibrillation. So how about these newer techniques to treat the risk of stroke? So as I mentioned earlier, the vast majority of strokes seem to occur in this little portion of the left atrium, the left atrial appendage. So through many types of cardiac surgeries, physicians or surgeons have done as part of their surgery to basically clip off this portion of the heart, thinking that it's not particularly useful. It's sort of appendage, so it's sort of the same kind of root word as your appendix in your intestine that people get surgery for. Turns out it may or may not be true. We don't know that for sure yet, but suffice to say that when folks undergo heart surgery, open heart surgery for other types of surgery, and they do have AFib, often a surgeon will elect or decide to take out that left atrial appendage, thinking that it may reduce the risk of blood clots. However, the data for doing that are very scarce, so there's really not much support, at least in terms of hard scientific evidence, that it does indeed reduce the risk of stroke. However, this is a very intriguing potential option for therapy for reducing the risk of stroke. So these are just a couple stock photos showing how some of the surgery is done. So you can have a device that basically clamps down and then cuts away, and you remove that surgically, or you can just physically cut things away as well. Now, I just wanted to use that to leap off to one of the newer technologies that potentially could be exciting, because it doesn't involve a major morbid surgery, which is cutting open the chest and then having that surgeon cut away that little piece of the left atrial appendage. And that is with the device. This looks like a little parachute, but this device can be deployed through those same types of catheters that we use for ablation, right into the opening of that appendage that I showed you, and then basically plug up that hole. This little artificial mesh material then gets coated with your body's own natural, what we call endothelial lining, and then it basically self-seals that part of the heart off from the rest of the heart. And there is a clinical study that was just published in the Lancet journal, which is a British medical journal, that showed that it is indeed effective. And so I'll leave it at, this is, again, quite an early stage of development, but it is at a stage where some early clinical studies show effectiveness and also safety of the procedure as well. So to summarize all of this, so I want to emphasize 3 points. Number one is, again, managing the risk of stroke versus controlling the AFib rhythm are, I think, independent tasks, really. And the decision on, number two, the decision on medical therapy for stroke risk, meaning aspirin, warfarin, other therapies, really depends on those risk factors that you have for stroke, given that you have AFib, that CHAD score that I mentioned. And then there are lots of new promising treatments, both medically, in terms of blood thinners, as well as potential devices for treating that left atrial appendage. And I'll stop there. Thank you very much. And I'll then lead on at that. You know, I've been talking about the blood thinning issue. Now, I mentioned all these issues about controlling the rhythm in atrial fibrillation with different techniques, and Dr. Alamat is going to take over from there.
Okay, so I'm going to talk to you a little bit about AFib ablation and surgery. I'll start with surgery because I'm not a surgeon. So really, the surgeons really started this whole kind of idea of treating atrial fibrillation with a procedure, and it initiated with Dr. James Cox's lab, initially at Duke University and then at Washington University in St. Louis, when he found that he could isolate the left atrium electrically by essentially creating scar lines. So when you cut something and you sew it back together again, you create a scar. And that scar is electrically inert. It's like when you cover the wire with a piece of plastic. And so it doesn't let conduction of the electrical impulses of AFib occur. And so in doing that, basically was able to terminate atrial fibrillation in a lot of patients. And this is sort of what it looks like. This is what a maze procedure looks like. You can see here the heart gets opened, and they create these lines where these lines are surgically cut and then sewn back together again. Now, they don't have to do cut and sew anymore. They have other devices that can do it, but this is able in many good surgical hands to eliminate atrial fibrillation. The effectiveness of this procedure is actually quite high if done in the full way. So if you have a full COX-3 maze procedure done with an open chest, the effectiveness is quite high in the range of in the 90% range, with a fairly low mortality given the fact that this is an open chest, open heart procedure. There's been other ways of doing this now, so not everybody wants to have their chest opened just for atrial fibrillation. Now, certainly if they were going to have a valve put in or they needed open heart surgery for another reason, it makes a lot of sense to do this in addition. But a lot of patients really are not interested in that full invasiveness. And so there are other ways you can do it, and those other ways involve other probes and things that have been developed for non-invasive atrial fibrillation ablation. Now, a lot of these are available, and surgeons all around are doing these. The data, however, is a little mixed. We don't have all the data on how effective it is, but I have seen some of these work, and I've seen some of these not work so well. I'm going to move on to AFib ablation, where we'll spend most of our time, in part because that's where our expertise really is. And really just to show you one important sort of landmark study that looked at this, and this is a paper by Michel Hasseguier in France. And basically he had the observation in only 45 patients that atrial fibrillation began around or near the pulmonary veins. Now, what does it look like? Well, I'm going to have to try and convince you that this is really something interesting to us, this spiky potential there. This sort of dull-looking one here, that's what the left atrial electrical activity looks like on the inside of the heart. And then this very sharp guy right next to it is what happens when the pulmonary vein fires. And so now when you have an extra beat, an atrial premature beat, the pulmonary vein fires first. And when you have atrial fibrillation, the pulmonary vein fires first and causes the left atrium to go into atrial fibrillation, in fact, the heart to go into atrial fibrillation. It really is the cause. And they were able to further prove this by simply cauterizing those areas or ablating those areas where that sharp, spiky potential was, and in doing so, really reduced the amount of atrial fibrillation that people had. So initial success rates were actually quite high, 80%, but we learned a lot from then. Now remember, this is a decade plus ago, and we learned that it wasn't just one pulmonary vein in most people, it was all 4 pulmonary veins that had the ability to do this. And we also found out that it wasn't just the pulmonary veins, it was some other areas in the heart, in the left atrium in particular, that can cause atrial fibrillation. So I'm going to show you a little bit about how we do this procedure, and just to give you an idea. These are some of the tools we might use. These are ablation catheters. So this is what Dr. Wong was telling you about. It's a plastic tube. It's essentially a wire on the inside, and it has an electrode tip here. And that electrode tip allows us to deliver radiofrequency energy to the inside of the heart. In addition, we'll often put up a catheter that looks like this. It's kind of a circular catheter. We call it a circular mapping catheter or a lasso catheter. And it has these little electrodes on it. You can see them right there. And those electrodes are able to measure the electrical activity on the inside of the heart and look for those sharp, spiky potentials that can cause atrial fibrillation in order for us to target those sites and eliminate them. This is what the left atrium looks like on the inside. You can see there's the pulmonary vein, that's the back wall, and another sort of area of pulmonary veins here. I hope nobody gets too dizzy looking at this. But you can see here that it's not a perfect, area. It's not a perfect circle with these little tubes coming off of it. They're not always, sometimes they're oval, they've got funny shapes to them, they've got ridges, they've got all sorts of things. And these are the areas that we have to target with our ablation technologies. Well, this is just to show you, this is an ultrasound here, and you can see, and this is a fluoroscopy shot, you can see here that we have our catheters next to the orifice of the pulmonary vein. This is the left atrium here, this is the pulmonary vein right there, and this is the same pulmonary vein now with our catheter on a fluoroscopy screen. And you can see we just move our catheters around different spots and simply cauterize the areas that might be causing atrial fibrillation. When we're done, it often looks like this. So you can see here, these are all the areas that we've moved that lasso or circular mapping catheter to. You can see that we've moved it all around the heart, and we've in fact delivered radiofrequency energy to all sorts of areas that have been a problem for that particular patient. Okay, so what do the results look like? Well, this is a summary of multiple studies, and you can see here that on average, and some of these studies included more than one attempted ablation per patient, but on average the results are pretty decent, about 80%. And this again is sort of a mixed bag of patients. Some of these patients had so-called paroxysmal AFib, as Dr. Wong mentioned to you, is the AFib that comes and goes on its own. And those patients certainly will have better results than those who don't. It's an invasive procedure, and you know, I would be remiss not to tell you that there are possibility of complications. In fact, the possibility of potentially serious ones. This was a study that was just published recently that looked at 45,000 procedures done for atrial fibrillation in the United States and in Europe, and compiled all the deaths that were reported and found that basically we're dealing with about a 1 in 1,000 risk of death with this type of invasive procedure. So who do we like? Who's a better candidate for atrial fibrillation ablation? What do I mean by better candidate? I mean, you know, certainly we want to do this on somebody who's symptomatic. As Dr. Shaw sort of told you earlier, it's hard to, in today, you know, with what we know today, taking somebody who has no symptoms and doing a procedure on that has some risk probably is not the right thing to do, although later on it might be if we have the data that supports that. So symptomatic patients certainly are patients that would fit in a group that would be good for AFib ablation. Now, if they have paroxysmal AFib that comes and goes, their likelihood of success is higher and their likelihood of needing more than one procedure is lower. Certainly people who have a very enlarged left atrium from years and years of disease, for example, rheumatic heart disease or other diseases, may have lower rates of success as well. And typically, based on the current guidelines, the American College of Cardiology, the American Heart Association, Heart Rhythm Society, they have to have tried an antiarrhythmic drug first and have failed that. And this is the same exact slide Dr. Shaw showed you, but again, I'll highlight that they have to have tried these before we take them to catheter ablation. Now again, there are some studies that are looking at reversing the role, trying catheter ablation first. And so these guidelines, which are updated every few years, may change to reflect that in the future, but we don't have that data yet. Just to show you a case of a patient that we did at Stanford, a 75-year-old woman who had atrial fibrillation despite medications. In fact, she was on a drug called sotalol. And unfortunately, she felt very poorly with the atrial fibrillation. She just didn't have her get up and go with it. She had multiple attempts to restore normal rhythm. Typically, these involved cardioversion or electrically shocking to try and restore normal rhythm. However, she would be in normal rhythm for a week or two and then back into atrial fibrillation. And so really maxed out on medicines and maxed out on attempts. And at this point, she's been in atrial fibrillation for a long time. Now I'm going to show you a 2-hour procedure, hopefully in less than 2 minutes. And so you can see here, this is a map that we create. And you have to sort of, you know, this is me moving the catheter around and touching the wall of the atrium to create this map. We're creating a geometry of what the left atrium is in this individual. And again, it's not perfectly accurate because it doesn't need to be for this particular purpose that we're using it for. But we're using this to sort of gauge where the arrhythmogenic areas are. And you can see here we're moving around and we're creating this map. These tubes here represent the pulmonary veins, and I've shown you before they're not perfect tubes, right? They're often funny-looking tubes. And here we start doing our ablation. We can see the red dots represent areas that we are ablating, areas that we think represent arrhythmogenic substrate, areas that cause arrhythmias in this individual. And moving around from one area to the next. Again, this procedure takes us in the left atrium about 2 hours, but overall between 3 to 4 hours to do the whole thing. Obviously, there's time to get set up and time to get into the left atrium. But once we're in the left atrium, typically in about 2 hours, we can accomplish what we need to in a fairly safe way. I will point out also that although there's been some deaths reported, obviously in the literature, we've been fortunate at Stanford not to have any bad complications. But here you can see we're going around and dotting around and finding these areas. And we keep doing this, hopefully until we can eliminate atrial fibrillation, or at least all the areas that cause atrial fibrillation. In some patients, that means we have to cardiovert them in the end. By shocking them. In other patients, we can terminate atrial fibrillation during the ablation procedure. Okay, so it's essentially more of the same here. And you can see here the density of these dots is growing in different areas. And we're covering all the areas around the veins, which are the areas that we know can cause atrial fibrillation. Okay, and what happened in this individual was her atrial fibrillation terminated during the ablation procedure. And in fact, she's been in normal rhythm now for, I think it's been 6 or 7 months, whereas in the past you couldn't stay in normal rhythm for more than a week or two. So in this individual, it's really, really helped her live a better quality of life, which is really what we're looking for right now with this kind of procedure. I'm going to tell you a little bit about some new things that are happening. This is called cryoablation, and this is still investigational in the United States. We've been one of about 10 centers or so in the country that's participating in this particular investigational protocol. And you can see here, this is the left atrium right here. That's a pulmonary vein that's outlined here with this contrast material that's been injected into it. This large balloon is called a cryoballoon. And it's basically a balloon that gets pushed up against the pulmonary vein. This is our circular mapping catheter that I told you about earlier. And this here is a ultrasound catheter that shows us what we're doing as we're doing it. And then these here are catheters that we place in the heart for other various reasons to make sure that we can control the heart rate and do other things like that if we need to. And essentially, what we do is we apply freezing to this pulmonary vein. And in doing so, with one shot, instead of going around and dotting all those areas, we can do this with one quick application, maybe sometimes more than one. But typically, this works really well. If you can get a very good seal on the pulmonary vein, it works really well. Just to show you, again, these are the spiky pulmonary vein potentials here. You can see a ton of them in this particular patient here. And that's before we did the cryoablation. And then after cryoablation, they're all gone. And so really quite impressive, the ability of this catheter to work. And we've been very impressed with the preliminary results that we've had at Stanford with this technology. And again, this is an investigational device. Just a word about some future studies, and this is the so-called Cabana study that we'll be starting at Stanford as one of the centers in the United States that'll be participating. And this will be a randomized study that'll look at ablation versus rate control strategy. So this may actually help answer some of the questions. As Dr. Shaw told you earlier, we think drugs may be good in some patients, but not great in other patients, at least some of the older drugs. And perhaps with ablation, we might be able to achieve normal rhythm and achieve better outcomes in terms of mortality without as much risk. We don't know that yet, and that's why it's part of a clinical study, but that's an important thing for us to find out as a group. So I'd like to conclude, AFib ablation, I think, is really becoming a very important strategy in the treatment of patients who have atrial fibrillation, and should really be considered for symptomatic patients. If somebody has symptoms, we really like to consider them for AFib ablation. And I think new technologies being developed may help make this safer and more effective. And with that, I'd like to thank everybody for their attention.
So I hope you've enjoyed the talk so far. And really what I'd like to do is conclude and really tell you a little bit about, and this is my personal opinion, about where the future lies. And really what I have to say is I think it's incredibly exciting. I think you've gotten a really strong flavor of this, and I really like to share that enthusiasm with you. So you've heard a little bit about the range of medications that exist, and one of the things that I did want to point out, and Dr. Shah mentioned, is that we do have a new medication. It's, medications, as you kind of might imagine, aren't introduced every day. In fact, it's been, nearly a decade since the last medication was introduced. So we're extremely excited to have another medication that's available, and that's a medication outlined here, which is called dronedarone. Goes by the trade name Multac. And indeed, I think will have an important role in being used in patients with atrial fibrillation. And this is an amiodarone-like molecule, but it doesn't have the structural elements that lead to what we believe to the vast majority of the side effects. So it's really quite free of the long list of side effects that amiodarone has. The other thing you've heard about from Dr. Alamad is really that of the real future and potential for atrial fibrillation ablation to make an important impact in the care of patients. And again, this is my personal opinion that I think these new technologies, the balloon technologies and others, will really have a major impact in making this something that can be used for a large number of patients. Along those lines, there are other technologies. One other major program that we're initiating now is using a special robotic system. I'm sure you've heard a lot about robots and robotics, and certainly now it's coming into use for cardiac, for the heart. And the use of this in catheter ablation for atrial fibrillation, I think, will be quite important and will allow us to treat a lot of patients that we couldn't treat in the past. And so this plus new ablation devices, I think, really give us great hope and promise for the future. This is an example of robotics. You can see a figure in the middle. It's really a joystick. It's a control system that instead of the physician touching the catheter, is able to simply control it as if you had the catheter in your hand and this was in the heart. New approaches you've heard for anticoagulation. We're really excited about this. Clearly more work needs to be done, it needs to be perfected, and some of the risks minimized, but we think there's great potential for this approach as well. I'll just put these up. These are a number of things that are called Stanford First that I'm very proud of, but I won't go into great detail. A number of the different books that our faculty has been involved in producing as well. Really to give you a sense that our philosophy has been to deliver outstanding care, but really one that is at the cutting edge. So not only we're using advanced technology and the newest technology, we believe we're developing that. And so as leaders in the field, we think we can, in fact, provide a great environment where we can provide this kind of outstanding care. Our research program, as you kind of see outlined in this quote that I made, really is an important part of what we do, and certainly would engage you in getting your support for that as well. So in doing so, I'd like to thank my faculty for their great insights, and I hope you'll join me in providing your appreciation for their support. Great. So I think it's appropriate to take your questions. We're happy to do so. Obviously, if your questions of a personal nature, we'll probably generalize in responding to you, and certainly we'll be available after if that's the kind of question we can be helpful in. And again, I really want to express my deep appreciation to you for being here this evening. And I'll ask my colleagues to come here. I apologize, as I had to leave for another engagement, but certainly Dr. Shah and Dr. Alamad will join me up here in being able to take your questions. Okay, certainly. So the question is, could we speak a little bit about exercise in the atrial fibrillation patient? So I'll make some initial comments and ask my colleagues to join me in this. So certainly there's several issues, and so one is that if one is in atrial fibrillation, the rate in general with exercise is more difficult to control. So ordinarily, if you were to go up that hill and your heart rate might go to 100 and 110, it might be 130 or 150 going up that same hill in atrial fibrillation. So we're a little mindful that to adjust one's medications to allow you to not have uncontrolled rates with exertion. So that's one certainly principle. The other thing is, in general, we don't prohibit people from exercising. We encourage people. It's part of health, et cetera, and so it's quite important. There are a certain number of people, however, and I think it's a relatively modest number of patients, for whom exercise is an important trigger. And for them, we try to work with them in terms of coming up with strategies, and they may need medication or other strategies such as catheter ablation to treat their atrial fibrillation. I don't know if my colleagues have other things they'd like to add to that overall.
Yeah, well, I think that one of the problems is rate control during exertion. So I normally ask the patient to avoid these activities that require sudden increase in the adrenaline level, maybe more a controlled, gradual increase in their activity, like on the controlled program treadmill or something, as opposed to get up and run up a flight of stairs, because then I think the heart rate tend to be more difficult to control if with sudden surges of adrenaline associated with activity.
The question is, it sounded like ablation is able to restore normal sinus rhythm, and is there any long-term data that suggests that restoring normal sinus rhythm will reduce the risk of stroke or make people live longer. And, you know, the answer really is we don't have that data, and that's where Cabana hopefully will come in. That's going to be a very important study that will help answer those kinds of questions, because, you know, I think we believe that restoring normal rhythm is probably better, but we don't really have that evidence. We have some suggestion of that from some of the prior studies, but even that's been murky because of the types of techniques that were used at the time to restore normal rhythm may have also added risk. And so that becomes one of the issues. Certainly the data that thus far, in terms of people who've been ablated years ago, seems to be okay. They seem to do reasonably well. We're not seeing people who've had excessive deaths. That's not been reported, although we really do need a good clinical study like Cabana to answer that question.
So I'd just like to echo Dr. Alamat's comments, and that is to say that we talk a lot about studies, and so we have a condition, over 2 million people have this, and so it's really important we get careful, scientifically obtained data to answer these questions. Otherwise, really, we practice with the best knowledge we have, but we want it to be the right knowledge. And so getting those answers to really improve people's quality of life, reduce the risk of stroke, is really important. And so that's indeed why we really are careful about looking at what the body of knowledge is, and not saying, oh, we believe that and we could say that's true, but rather we really want to give you the practice based on that knowledge as best as we can determine it. Dr. Shah, you want to repeat that first?
The question is, for controlled atrial fibrillation, the patient takes a beta blocker and drinks decaf, whether or not the patient can switch back to a regular coffee, and so he doesn't feel as tired. Well, we know that the caffeine can be a trigger, and adrenaline or catecholamine can be a trigger. So and beta blocker is used to suppress that. I think the answer to your question is yes. I think you could drink regular coffee, but everything has to be in moderation, and each patient has to be treated as individuals. So there's no absolute contraindication to drink coffee as long as you. But some people are different people have different triggers. Some people are exquisitely sensitive to wine, a certain type of wine, and we don't know why that's the case. I had a patient who gets into atrial fibrillation every time he yawns because or he drinks, after he's eating certain food, because the esophagus is right behind the left atrium. So I think it has to be individualized, but in general, I don't think there's any absolute contraindication to not be able to drink coffee if you enjoy coffee. Just don't drink something too strong. The question, does atenolol make you tired? Atenolol is just one of many different beta blockers. And there are different even though there are about 10, 15 different, maybe a dozen or 15 different beta blockers, they have different properties, and they have different effects on the heart and different effect on the central nervous system. So certain beta blockers may make patient tired. So to switch to if atenolol make you feel tired, to switch to a different type is a very viable alternative, or a choice to do.
So it's very interesting. Certainly, as we talked about, most patients don't develop atrial fibrillation a few decades, a number of decades ago, and they're more likely to do that at a more advanced age. We do know that there are some genetic abnormalities that we think are predisposing of atrial fibrillation. So the question really related to you have atrial fibrillation, and you've had it for since you were a young individual, a younger individual, I should say, and so what what can we say about that, and particularly the risk of stroke? And so we don't really know, as a subcategory, whether the risk of stroke is any different. We do think that the same risk factors of these medical conditions, such as Dr. Zais mentioned, such as diabetes, heart failure, hypertension, high blood pressure, and age, serve as important risk factors, regardless of whether it's genetically based or not. And that's our current dogma. But indeed, we're going to learn more about it very, very soon and very rapidly.
Yeah, so that's a great question. The question is, what's the success rate of AF ablation, and how long can somebody expect to stay in normal rhythm after AF ablation? I think it's fairly individual based on the type of AF that they have. Is it paroxysmal? Is it persistent? The age of the patient, things like that. I would say that if you've had a successful atrial fibrillation ablation, you have a very good chance of remaining in normal rhythm. However, there has been some data from other centers that have suggested about a 5 to 10% per year of people will fall out of that if they've had a successful ablation. We've had patients now we've followed for 2, 3, 4 years who've remained in normal rhythm after a successful ablation, but there have been others that have sort of needed a second ablation 2 years later or 3 years later. And you know, we think of this as a way to manage the disease in some ways. One other comment, I apologize for taking a little, but you know, AF ablation is one way to manage the disease, but we're also dealing with all sorts of other things that can cause or promote AFib. For example, you know, just to give you one example that I think will highlight this, we had a gentleman who had a successful AF ablation, was in normal rhythm for 2 years, and then the next time I saw him, he'd gained literally 100 pounds, had stopped being able to move and had severe sleep apnea, hypertension, and now he developed AF again. And so you can only do so much. I mean, you sort of are fighting this uphill battle of aging and other disease processes that are going on. And so that needs to be taken into consideration as well.
I would like to just echo Dr. Alamad's comment. I think that atrial fibrillation is a very common disease, and you know, it can occur in very young individuals. It can occur in older individuals. It's the same rhythm, but they're clearly different disease. You know, atrial fibrillation in a 30-year-old is probably not the same as atrial fibrillation in an 80-year-old with you know, bad heart, bad valve, sleep apnea. So I think the treatment of or the management of these other risk factors, we are learning more and more about various different risk factors that's above and beyond these CHAD scores. You know, sleep apnea is one of them. Some of their other data suggest cholesterol could be one of them that people are learning more, and genetics is one of them people are learning more and more. And we have to manage all these other risk factors, or should I say the patient has to manage all these other risk factors as well, in addition to having you know, a catheter ablation.
Excellent question. So I'll repeat that. So the question is, if diabetes, for example, is a risk factor for stroke in atrial fibrillation, and it's well controlled, is that considered a risk factor? And indeed, well controlled or controlled diabetes or high blood pressure are still considered risk factors. It is a bit of a puzzle because you could say, gee, it's well controlled, why would it be a risk factor? And so we don't know the answer exactly why that's true, but the data we have still support that, yes, it is a risk factor. Okay, great. So the question was, how about cardioversion? We didn't mention much about that, and is that not being used? And I would just very simply say, no, very much so. For patients that are in atrial fibrillation that is persistent, we would use typically a combination of a medication and cardioversion, and that can do very well in terms of controlling many patients.
So the question is, because with ablation we're working close to the pulmonary vessels, is there a risk of pulmonary hypertension? So one of the things that has been learned throughout the years of doing ablation is we don't want to be too close to the pulmonary vessels. In fact, ablating inside the pulmonary vessels is probably a big no-no because in the past there's been reports of patients developing something called pulmonary vein stenosis, which is a tightening of the vessels, and that can then lead to high blood pressure in the pulmonary arteries called pulmonary hypertension. which is not a good condition to have. And so one of the reasons we do the way we do it with ultrasound catheter in the heart and with the X-rays and with these extra maps that we have is really to avoid these types of pitfalls that people have learned along the way. We want to look and make sure we're not inside the vessel and we're ablating where we need to ablate, but not in an area that might cause undue risk.
Yes, good question. So the question's excellent. Aspirin, 81 milligrams or 325 milligrams. And so in general, we would, most of the data are based on full dose aspirin, unlike for prevention for heart attacks where 81 milligrams often is used. Okay. I'll turn to Dr. Shah. Yeah.
The question is medication, Defitelai, how is it compared to amiodarone or sotalol? That's a very good question. I mean, the Defitelai, and amiodarone and sotalol are all considered, they're all within the same class of antiarrhythmic drug in terms of their general action. And each drug really has its pluses and minuses. And so in terms of Defitelai, it has a similar effect of amiodarone, not all the effect of amiodarone. Its major limitation is because it's clear by the kidney, so the patient has to have a reasonable kidney function. Sotalol is a kinder, well, it's basically Defitelai plus a beta blocker. You can think of it that way. So it has a beta blocker effect in addition to a Defitelai-like effect. But the beta blocker, sometimes make patients feel tired or whatever. And amiodarone, on the other hand, has functions of all of them. It's a beta blocker. It's a calcium channel blocker. It has Defitelai-like property, and it has other drugs properties. So amiodarone is a very, very complex drug, and it is still probably the most effective agent we have today. But unfortunately, it is also associated with a lot more long-term side effects with amiodarone. So it has to be, and has a lot of interaction with other drugs. It can be used and can be managed very effectively on amiodarone or any of these drugs, but the patient has to be followed closely. And in terms of which drug to choose, I think that's really, again, it depends on the side effect profile and the individual patient's history and other medical problems, and then we have to choose one versus the other one. Well, they all have that sort of side effects. So that's why drugs like Defitelai, actually you need to go to a course and get some sort of specialized, specialized certification in order to use Defitelai. It has to be started as an inpatient and has to be monitored for that reason.
Great. So I'd like to again apologize. You may have additional questions. We're certainly happy to answer them best we can. But I'd like to thank my faculty certainly very much for providing a very educational program, which I hope you enjoyed. I'd like to thank Nora Kane and the Health Library for making this possible. So again, thank you very much to you for participating tonight. Thank you.
For more, please visit us at stanford.edu.